This is QD Clinic. I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.live in January. You know, this is a great board review course. I'll tell you why at the end. Today's case is scleroderma. And I say scleroderma because when I see new scleroderma, I'm thinking to myself, Ask any rheumatologist, do you want to take care of 10 fibromyalgia patients or one diffuse systemic sclerosis patient? I mean, that's an equation that it's just mind-boggling. It's mind-bending. There is no right answer. They're both difficult. And scleroderma is difficult because we just don't have the answers we want. So let me give you a new case I saw in my approach to a new case. And at least this is how I start. You know, it's the management of all the ramifications and complications and extensions of disease and scleroderma that make it difficult. This is a young man, 40 years old, referred to me because he had a positive ANA and had to quit his job as a mechanic. Could no longer use his hands. What he described was really bad rainouts, but also that he just couldn't open and close his hands. So his problems began maybe 2 years ago after COVID. Then he caught COVID. And after that, although COVID he got over with, a few months later, really severe shortness of breath, dyspnea on exertion, fatigue, and some chest pain. Went to the emergency room, no diagnosis, I'm not sure why, we have no records. Given a steroid shot, kind of got better, no more lung symptoms. But then, maybe a year ago, he starts in with noticing the hair on his arms and armpits and legs are going away. He develops a tightness in his hands with rainouts. And this happens every day. He now has difficulty, opening a water bottle or tying his shoelaces. He sees a primary care doctor who puts him on very low dose calcium channel blocker and sends him to me. When I see him, he has serious, bad, 3+, leather-bound skin over the fingers. And when you do he's got sclerodactyly over the fingers, back of the hands, and even up to the forearms, not above the elbow. Not on the face, not on the chest, abdomen, legs, ankles, or feet. He's got pretty severe rainouts, both blanching and reactive hyperemia erythema. No cyanosis. So he's got biphasic rainouts. When you look at his skin, his digital pulp on his fingertips, they're normal. He has no pitting scars, right? He has no loss of pulp in the fingers. When you do a skin exam and quantify the amount of skin tightness, he has a modified Rodnan skin score of 14, which that's a high number for me. And you should know how to do a modified Rodnan skin score because it's the one tool you can do to follow people serially as they go on. He has no swollen joints, no tender joints. His fingers look a little sausage-like, I must say. And no, he cannot fully close his fingers and make a full fist. He has no tender points. He has no other skin manifestations. His labs show a normal CBC, chem profile, a normal acute phase reactants. He's got a TSH that's normal. A UA shows no proteinuria. He's not anemic. He has normal LFTs and albumin. His ANA is 1 to 320 in a nucleolar pattern. Other autoantibodies were done and show him to have negative SSA, SSB, negative SM and RNP, negative for SCL70, normal sed-rate CRP and a normal ferritin, no sign of prior Hep B or Hep C infection, no sign of thyroid disease. So he has early scleroderma, at least a year old, maybe 2 years old. He has noticed change so that in the last month he's had to stop work. The question is he at the crossroads of limited disease, crest, which is scleroderma below the elbow and no other organ involvement? Or does he have more diffuse disease? Diffuse would be suggested by a year ago, shortness of breath and dyspnea on exertion, but he doesn't have that now. Diffuse disease might be suggested by 30 pounds of weight loss I didn't tell you about, and he doesn't have anorexia and no history of ulcer, not taking nonsteroidals. What's the weight loss all about? And what are you going to do with this guy to start with? And that's really what this case is about. What's your initial steps? I'm calling this officially limited disease, but I'm very worried about diffuse disease. I explain the differences. The hardest part of this visit is explaining scleroderma, the two types, the potential for serious bad outcomes with the diffuse type. But that scleroderma is difficult to manage. Scleroderma doesn't have a known cure or treatment. So what am I going to do? My first order of business is to get him to physical therapy, teach him how to protect his skin, try to improve hand mobility and skin tightness with local warmth hand warmers. You can buy these USB charged hand warmers on Amazon for like 10 to 15 bucks. And patients can have them in their pocket and they can put them in their hands when they're getting bad rainouts. Second thing is I like to recommend my patients to try using, when their hands are like this guy's, paraffin wax baths. And if they've never had one or done one, they can go to a nail salon, get their nails done, and ask for a paraffin wax treatment. And then if they like it and how it feels, then they can buy one for about 30 bucks and have one at home and use that twice a day. So physical therapy, advice on work and career, and then medicines. I'm of the belief, one, that there's no great medicine for scleroderma, and I've tried everything. I do believe the data on limited and focal disease, including morphia, on the efficacy of methotrexate. So I put all my patients on methotrexate as a first step. Methotrexate, usual doses, 15 to 20 milligrams a day with daily folate, giving them warnings about methotrexate. My second therapy is if they have pain or joint problems, I deal with that, but I don't like to use nonsteroidals. I certainly don't like to use steroids. I'll use analgesic drugs as best I can, Tylenol, Tramadol, etc. Will I ever use steroids in early scleroderma? Only if they have acute, new onset, incredibly puffy fingers and edema or sudden exacerbation, worsening of lung disease that I think could be early ILD or worse. So you evaluate that with imaging and maybe pulmonary, but I'll use steroids. And if I'm going to use steroids, I'm going to use high doses like 60, 40, 30, 20, 10, and whatnot. But I worry about steroid use in scleroderma and early scleroderma because I don't want to be a co-conspirator in the outcome of renal crisis. So no, I did not give this guy steroids. He had some aches and pains, but not much. He was not at the puffy stage. And by the way, I've given a lot of steroids in people who I thought might benefit from steroids because that's what literature says. I rarely have ever seen people do dramatically well from that initial course of steroids. Hence, I don't really believe in its use. So I have to be pushed to use that in the in people that I think could benefit. My next most important thing is I'm worried about their vascular disease. As you know, scleroderma really isn't a fibrosis disease as much as it's a microvascular disease that drives fibrosis. Treat the underlying vasculopathy and maybe you'll have better outcomes. Hence, everybody that I diagnose with scleroderma goes on low-dose aspirin and low-dose statin, regardless of whether they have, a hyperlipidemia. And I know you could say that's crazy, but you come up with your own crazy ideas because nothing works. So that's what I'm doing until someone comes up with a better idea. Low-dose statin has never gotten any of my patients into trouble. Also, everybody goes on either a calcium channel blocker, and I prefer those over ACE inhibitors to prevent renal crisis and to manage the possibility of renal damage, but more importantly, to manage these symptoms. And you may have to drive the dose up to better manage their rain out symptoms and to stabilize that. So this guy went on a higher dose of a calcium channel blocker, aspirin, and a very low dose of lovastatin. In the future, I tend to use JAK inhibitors. I tend to even consider rituximab. I don't have any great solutions beyond that. As you know, the literature is horrible on this. Please come up with a solution. And really, my future in management is going to be based on what they have. GI symptoms, I'm doing H. pylori and sending them GI and let them do H. pylori or endoscopy or further evaluations. Lung symptoms, it's pulmonary and rheumatology working together. Skin problems, I send them to dermatology. I have a lot of great dermatologists who really know how to manage scleroderma and its complications, including ulcers, including calcinosis, and I co-manage with them. But this is my early management of scleroderma. Tell me how you manage scleroderma when you meet me. Come to RheumNow.live and meet me and tell me. RheumNow.live is a great board review course. Why do I say that? Well, number one, it's easy. It's cheaper than other of these regional arthritis review courses. It's 1.5 days over the weekend. There are state-of-the-art clinical updates given by world-class faculty, where in the course of their great state-of-the-art lectures, you're going to ask all the questions that you want. We have modules, 2-hour blocks on RA, PSA, spondyloarthritis, vasculitis, and a little more than a 1-hour block on lupus. We have TED Talks, short talks on myositis, gout, immunosenescence, and managing the literature or critiquing the literature. And in the end, after the meeting, you'll get a bank of board questions from which you can study. Everybody that registers gets all this. Again, prepare for the boards. Come to RheumNow.live, January 27, 28. Register at RheumNow.live and make your hotel appointment. It gets more expensive after January 5th.